Thank you. Thank you very much for this opportunity. Can you hear me? Thank you very much for this opportunity. It's really a pleasure to be here. I am speaking today as a physician and a reluctant person in the debate about this practice in the United States. I have, although I've done research in this area and did the first large survey of physicians in Washington State before it was legal anywhere, a study that showed that 12% of primary care physicians received requests from patients for physician-assisted dying, and this was around the height of the AIDS epidemic, when the use of physician-assisted death practices that were illegal were kind of an open secret in the United States. That said, I deliberately stepped back from this research because the social experiment was happening right next door to me in Oregon, and also because I view this as a kind of a social experiment that we are still trying to understand. And I think I have clearly learned some things about the nature of death and the process of dying with technological means in a society that is struggling with its own mortality, I would say. So I have not spoken on behalf of any advocacy organizations in the United States. I did not participate in the political process in Washington or Oregon. As an oncologist, I feel like my patients have enough to worry about without worrying whether or not I am going to subtly try and suggest that physician-assisted death is a good thing. So I just wanted to be really clear about where I stand. That said, I have gone on record as saying that in the current context of the United States, I think that it has become a part of the discussion of end-of-life care in the United States. And because of that, I do not think that the medical profession can afford to stand back and say this is not allowable. I feel like the public has clearly spoken on this matter. And what the public is saying in North America and in Europe is that they want access, right? As of now, 86 million people in the world live in a legal jurisdiction where some form of physician-assisted death is legal. And so as such, I don't think we can consider it kind of a quirky practice anymore. I mean, it's part of the mainstream, and I think the important thing in this discussion, and the reason I came here to participate in this very interesting discussion, is because I think there's even though patients who want this practice are very vocal and very prominent in the public debate, in reality, it's a very small number of people who actually carry through it. So as an oncologist, I talk about this all the time with patients. It's actually rare that a patient doesn't bring it up. And yet, of those patients, the number of them who proceed to engage in the legal process to obtain a lethal prescription is very, very small. You know, as Professor Smer pointed out, there are a variety of terms that have been used, and these are just some of them that have been used in the United States. The one thing I wish to point out is that I have really backed away from the use of the term physician-assisted suicide because I think this phenomenon is not suicide. It is clearly different than the psychiatric illnesses that lead to people to, kill themselves by means. These are not people who are trying to kill themselves. These are not people who are trying to end their lives early. These are people who are trying to struggle with their mortality. And so because of that, in Washington State for a long time we used the term hastening death, and more recently have really gravitated to the term using the Death with Dignity Act simply because it seems like the least judgmental and the most purely descriptive. So when I speak of it in the United States, I speak of patients who are using the Death with Dignity Act. I'm going to speak from a couple of different perspectives so that you can see what is happening in the United States right now. I'm essentially an empiricist at heart, and so I'm going to show you some of the data. Physician-assisted death is legal in the United States in these areas now. Colorado and Washington, D.C. just made this legal in the recent November elections. But as you can see, Oregon was the forerunner by a considerable margin and legalized this practice in 1994. Washington State, where I live, was the second state in the United States for it to become legal, but it did not happen for 14 years later. Washington State, where I live, is actually in many ways comparable to Sweden. You can see the total number of people is not that different, 7 million versus 9.6 million. The percentage of people in the state who are over 65 is not that different, 14% versus 19%. The total number of deaths in Washington State versus Sweden is 54,000 deaths versus 90,000 deaths. Notably in Washington State, despite the improvements with the Affordable Care Act, Obamacare, there's still over 7% of people who have no insurance coverage whatsoever, which of course is not the case here. If you look at the 54,000 deaths in my state in the past year, here are the top 5 reasons for death. And these are similar to Sweden and similar in every industrialized country. Cancer, heart disease, dementia, including Alzheimer's disease, accidents, and chronic obstructive pulmonary disease. Those are the top 5. You can see that of these 54,000 deaths, the number of physician-assisted deaths that occurred in our state last year was 166. So this was 0.003% of people who died actually wanted to go through this process and use a prescription for medicine to end their lives early. This is no different than in Oregon. And if you look at the data in both Oregon and Washington, although these numbers have increased very slightly over the past years, and of course there's over a decade of experience in Oregon, I mean, it's still a really small number of people. So this is a really small percentage of people who have, in general, a very strong focus on personal autonomy, a very strong focus on personal control, and they are outliers in a number of ways. There are lots of people who talk about it, but there are very few people who wish to proceed with the process. I'm going to just go through a few points about the Washington law, which is essentially identical to what is done in Oregon. And here are the safeguards. You have to be over 18. You need to be mentally competent as judged by your treating physician. You have to have a terminal illness that is expected to end your life in less than 6 months. There is a fixed 15-day waiting period after the first request that cannot be changed. The treating physician can require that the patient have a mental health consultation if there is some concern about depression or some other psychiatric condition that might be impairing judgment, and the patient must self-administer the medicine. Of course, since most of these deaths occur at home, we don't always know exactly what's happening, but certainly in the general instructions, patients and families are instructed that the patient must take the medicine themselves. These requirements are generally supported by public opinion. So this is an internet poll that was done last year in the United States. Should assisted suicide be allowed? This is about 1,000 people in the United States. The vast majority of them, you can see 54% of them favor the availability of assisted suicide for people who are terminally ill with less than 6 months. And I'm again using the term assisted suicide here because that was the term that was used in this poll. However, for patients who have severe pain or disability but who are not terminally ill, public opinion in the United States is much more split. And you can see here, it's in fact even at 36% to 36%. And then, of course, there are a few other responses that are not included in this poll. But I do think this poll suggests that, at least in the current climate of the United States, that the availability of these practices for people who have terminal illness is much more accepted than for people who do not have a terminal illness. Now, here is what happened in the past year in Washington State. 213 people who met those criteria received a prescription for a lethal medication. The lethal medication was previously exactly the same as what is used in the Netherlands, barbiturate and a beta blocker. But recently, because of medicine changes, the pharmaceutical manufacturer of barbiturates did not wish to be associated with this practice and raised the price of the medication to somewhere between $5,000 and $8,000 for the prescription. So because of that, the advocacy organization that I'll tell you more about has developed a new cocktail of medicines, which it has used for about 25 cases, and it has become the new standard. And the only reason that it was changed was because of cost. Of the 213 people who received a prescription, 166 took the medication and died. 24 of them died without using the medication of natural causes. 12 died of unknown causes. I think this is actually an artifact of the reporting because the report ends, and I think the people who died at the end of the year, the reporting isn't complete. My expectation is that those 12 are split in the same proportion of those who used the medication and those who did not. These statistics are typical for what has happened in Washington over the past several years where the legislation has been in effect. I will say that the percentage of people in 2015 who died after using the medication is slightly higher than in the past. In the past, it's been more 50-50. So I don't know whether or not this is a real trend or not. But it's clear, even looking at this, in the experience in Washington and Oregon, that there are a number of patients who go through the entire process so that they can have medication available to them if things get too bad and end up yet not using it. Who uses the law in Washington? So of the 2015 recipients, 53% of them were male, 73% were older than 65, 98% of them were white Caucasian, 95% of them live west of the Cascade Mountains, which run through the middle of our state, and that is a proxy for saying that these are people who live in an urban area. So they're basically well-educated Caucasian men and women. Again, this is very similar to what has been documented in Oregon for the entire course of the Oregon experience. Why do patients ask? 72% of these patients have advanced cancer. 8% of them had a neurodegenerative disease, such as amyotrophic lateral sclerosis. The remaining 20% of patients had a mixed bag of other terminal illnesses, including heart disease, etc. There are no patients with dementia in our sample because they generally don't qualify under the terms of the law. There are no patients with psychiatric illness because they also do not qualify under the terms of the law. The reasons that these patients cite, because this is part of the required reporting that physicians do, is that they actually are asked to indicate the patient's reasons for wanting to pursue a physician-assisted death when they do the reporting. The top 3 reasons are loss of autonomy, that they are unable to engage in activities that make life enjoyable, and that they have lost dignity. And there are a few more, but clearly these are the top 3, and they have come up again and again since the survey that I did even before these practices were legal. It's interesting, as a palliative care physician, that these are non-physical causes of suffering. We are generally not talking about people with intolerable pain, for example, as people who are requesting a physician-assisted death. It is generally more psychological / existential / spiritual. Are there complications? The median time to death is actually less than an hour. 63% of the people died in less than 90 minutes. Again, this is part of the reporting requirement that happens. There were 0 patients that awakened after their medications, which was not always the case in the pre-legal era. There were 0 cases where an ambulance was called for something related to the intervention and ingestion of the medication. So basically what we have now is a relatively safe procedure. That, in general, works. What is the patient and family perspective? This is a patient of mine who used the Death with Dignity law about a month ago. His name is Alan Smith. That is his wife, Petra, next to him. They are on a hiking trip in Florence. He was a 55-year-old software engineer who got initially stage 3 colon cancer about 5 years ago. He was treated with resection and received adjuvant chemotherapy. He developed a very severe neuropathy because of the adjuvant chemotherapy, a common complication, but his was so severe that he was unable to type, which for a software engineer is a career-ending complication. 2 years after his initial treatment for cancer, he developed a lung metastasis and had some chemotherapy and some radiation, but decided to stop his chemotherapy because he wanted to spend his time with his wife, and he was an avid hiker. He spent the last 2 years of his life taking hiking trips when he could, and his wife, you can see there, is German, and they spent some time in Germany together. As his cancer progressed, he started to have more pain from a sacral metastasis that had been irradiated. He did not wish to have an invasive nerve block for the pain. The pain was managed with long-acting and short-acting opioid medications, but when he became housebound and unable to get outside, he basically felt like he was done. So like many patients, he started with the Death with Dignity process kind of preemptively. He wanted to have the medication available in case things got too bad. When he became actually close to the time of death, I actually don't think it was intolerable suffering that made him decide to use the medication. I think he just felt like his life was over and that he had done everything he wanted to do. One of the things I have learned from patients who engage in this process is that the fact that they are planning ahead in this way somehow motivates them to do much more about life closure than other patients I take care of. They see people, they write letters, they have parties, they get everything ready. It's a very different last couple of weeks of life than other patients with cancer that I take care of. As is my practice, I spoke to him the day that he took the medication. I did not see him in person because I usually don't. He had been receiving counseling for the past 3 months, the last 3 months of his life, from our local advocacy organization that does very extensive patient and family counseling and instruction about using the medication. And they are the ones who basically developed the process in Oregon and in Washington for getting patients psychologically prepared, getting family members prepared, and instructing people about what to do on the day they take their medication. There is a volunteer from this organization that goes to be with families and patients on the day they take their medication and stays with them through the process. The reason I mention this is because this is a kind of technical assistance that I think has been very important in both the Washington and Oregon experience, and that I think is not easily scaled up. The volunteers that are doing this in Washington and Oregon are mostly retired clinicians, psychologists, and physicians, and they have a very high level of expertise and spend a considerable amount of their own time staying current with how to take care of patients. The other thing that is important is that knowing what to do at the time you take your medication is very important for families. I studied a number of cases of attempted physician-assisted suicides in the pre-legal era, where complications occurred, the medication didn't work, the family was in a panic, didn't know what to do. Some crazy stories happened, and those families had incredible complicated grief afterwards. And so as I look back on my experience watching physician-assisted deaths, I have seen both some of the best deaths I've ever seen and then a couple of the worst deaths I have ever seen because of incredible family trauma that they have never recovered from. It turns out Alan had quite a good experience. He and his wife drove back to one of their old hiking places on the day before his last day of life. On his last day of life, he had a few friends over. He asked them to leave. The volunteer came over. He and his wife spent a little time together. He took his meds. He lost consciousness about 10 minutes later and died quite peacefully. His wife is completely at peace with this. She feels, in retrospect, it was the perfect way for him to go. And she feels like she has absolutely no regrets about this. She was happy to share this picture with me because I told her that I was coming here to talk to the Swedish government about this practice, and she encouraged me to use their story as an example of a death that went smoothly. And she is very grateful, and he was very grateful for the opportunity to use this legislation. That said, I just want to put this in perspective of, what's happening with end-of-life care. And so these are some, assorted statistics about Washington State and the U.S. that just show where we are. 70% of people in the United States say they want to die at home, but only 32% of them actually do die at home, right? The rest of them are dying in ICUs, nursing homes, acute care hospitals. A recent study showed that, this was a look-back study of family members who were talking about their patients' last days, and said 57% of them said that the patient had had moderate to severe pain in the last days of life, right? All of you who are palliative care clinicians, no, this means someone is not getting good medical care, right? It's not, okay. And it's not good care if someone is having moderate to severe pain in their last days of life, right? We have pain technology. This raises a question to me about how well we do as a country in the United States providing routine access to high quality palliative care. And, the reality is we are still trying to do this, and we're trying to provide physician-assisted death too. But I just mean this as a point to say that doing a good job with physician-assisted death doesn't solve any of these problems, right? So it's not, because physician-assisted death is a practice used by a very small percentage of patients, it is not a proxy for what happens in the rest of the system about palliative care at the end of life. I wanted to say a few words about the public perspective in the United States because we've had a very interesting public discussion over the past 20 years about this discussion. You might remember Jack Kevorkian. He was a retired pathologist who was, honestly, he was a wacko. He was a retired pathologist who had never seen patients, who wanted to do physician-assisted dying, and he set up these little contraptions with lethal medications that patients could press a button and give to themselves. And he actually had a patient use one of these little contraptions on 60 Minutes and was promptly arrested after that. He did go to jail because he just wouldn't stop doing it, but it was a lightning rod for the whole discussion in the United States. And, I don't know that it really helped the real process. More compellingly, this is Brittany Maynard. She was a young woman with a brain cancer who realized that she would have to leave her home in California and move to Oregon because she wanted to have a physician-assisted death. She made a very powerful YouTube video that went viral. In the months before the California referendum, it was funded by the advocacy organization Compassion and Choices and was part of a well-orchestrated campaign to pass the legislation in California, which passed by a wide margin. And in fact, if you look at the states in the United States where the legislation has occurred, almost all of the states except one have had this passed by a referendum, a vote, a popular vote. And in every state, it's passed by a wide margin. In Washington, it was 57% yes. In Oregon, when the law was first passed, they had to pass it twice because there was a huge legal battle. There was the idea that they were going to vote twice. Oregonians were pissed off that the government was asking them to vote twice, and the second time they voted, it passed by a wider margin than the first time. This is despite the fact that the Catholic Church and a number of right-to-life groups spent probably more than $25 million on a public advertising campaign in that state, and have spent similar amounts of money in every single state where this has passed. So it's been a big public battle. Jerry Brown, the governor of California, is an interesting guy, and he was trained as a Jesuit priest, and yet he signed the California legislation because he says at the bottom, this is his this is the bill. In the end, I was left to reflect on what I would want in the face of my own death. I do not know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I wouldn't deny that right to others. Right. The way he puts this, I think, completely encapsulates the shift in the American public perception around this issue. Right. He doesn't know what he'd do, but he wants to have the option for later. And I think this shift is what has been important in the United States because many, many patients want this as a preemptive kind of issue. They want to be able to have the meds available kind of as the trap door out if dying gets to be too awful. But for many of them, they actually don't even go through the process because they realize as they are dealing with their illness that most of what they need will be able to get managed. And I think that is the reason this will likely remain a very small number of cases. That is, however, something that, a situation that I think is in play with the current set of safeguards. This is the website for the patient advocacy organization in Washington State. It's now called End of Life Washington. For political internal reasons, they have separated from the National Compassion and Choices organization. You can see the way they play this to the public is quite inclusive about dying, and they provide a lot of very practical information about end-of-life counseling, whether or not you want to have a physician-assisted death, advanced directives, whether or not you want to have them. And they have taken a very broad brushstroke public service approach to this. And in fact, I think it's been entirely beneficial to the discussion of end-of-life care in Washington and Oregon. And I can certainly say that I'm not sure, it's kind of a chicken or egg question about whether or not palliative care has gotten better or, despite this or because of it. Certainly in Oregon, when the legislation was first passed, there was a flurry of physician education and interest in what to do because physicians in general were completely freaked out about not knowing what to do. And the same level of education did not happen in Washington State, which is right next door, until we passed the legislation. And so I do think there is something about having this legislation present that makes physicians feel that they need to know how to deal with these requests. And in fact, that is the skill set that needs to be disseminated widely if this kind of legislation is put into practice. You know, from the physician perspective, I mentioned that physicians have been getting these kinds of requests for many years, right? This is from quite a while ago, the first survey I was talking about. And what we've learned from the studies since then is that responding to requests for physician-assisted death is not all about what dose of medication to take. It is about how you are living your life, what kind of suffering you have, what your goals are. This is a matter of communication skills, and it turns out very few physicians, even in Washington, Oregon, have had the communication skill training needed to effectively respond to requests. The major pitfall that I have seen is for patients to raise this as a "what do you think about this, doctor?" question, and for the doctor to go right into the requirements of the law, when in fact, what the doctor needs to do is step back and say, "Hey, tell me why you are asking this. What are you worried about? Why are you asking now?" Right? Those are the key questions, and for most physicians, it requires training because they were not trained how to do it when they were learning. Oh, wow. Okay. I was part of this editorial in JAMA earlier this year with Tim Quill and Susan Block. Tim was the American physician who brought this practice to public attention in the New England Journal of Medicine. In this editorial, we really used a kind of a harm reduction argument for the importance of having a practice for physician-assisted dying. It's clear to me that the public wants this. I think physicians need to know how to respond in a responsible way, and I think public policy needs to match. As I mentioned, I view this as a kind of social experiment, so I'm a little more concerned about understanding the experience and outcomes of the patients who are currently using the process than in trying to expand eligibility, which I view as an advocacy kind of interest. I mentioned a request for physician-assisted death should really prompt a discussion about goals of care, right? All of you palliative care physicians in the audience know that this is what good palliative care is about, and yet it tends to get lost in all these discussions about, do you meet this requirement or that requirement? Linda Ganzini and I wrote in JAMA Internal Medicine earlier this year about some of the differences between what's happening in the Netherlands and Belgium versus what's happening in the United States. And there are some troubling differences. There is a part of Belgium where the use of euthanasia has risen quite dramatically over the past 10 years to rates that worry even Belgian physicians. The rate of what's called continuous deep sedation, which is their term for terminal sedation, has risen from about 4% of the population, much, much higher than the United States already, to 15%, which is, unheard of in an American major hospital about terminal sedation. In contrast, the use of physician-assisted suicide, as if you judge by prescriptions written, it's gone from 0.6 per 1,000 deaths in Oregon to 3 per 1,000 deaths. So it's a very small increase. It's an increase that's true, but it's still a very small percentage of patients. This is still quite a bit lower in some of the European areas where this is currently legal and where the Dutch model is used. I can't say that the nature of the legislation accounts for the entire difference in practice. I mean, clearly there are a number of cultural differences in addition, but it certainly has raised the question in my mind about the importance of safeguards as a way to understand, safeguards as a way to make sure the practice is bounded, and the importance of public reporting so that there is ongoing analysis about what's happening. I wanted to come back to the issue of suicide, the use of the term suicide, because one of the things I have learned as a clinician in talking to these patients is that there are a whole bunch of different things going on, and none of them actually are suicide in the typical sense, right? Suicide is usually, most frequently, the outcome of someone who has a clinical severe depression, right? Where they are so unactivated, unable to do anything, unable to have any joy, that they see killing themselves as the only way out of their lives, right? That is not what most of the patients that virtually all the patients I see are dealing with. If you have a true clinical depression, you probably won't be able to go through the whole process of going through all the visits for the physician-assisted legislation because you're too deep, you're too flat to do it. What I see are patients who are grieving, they're sad. Some of them have what the psychiatrists would call demoralization syndrome. Those are treated in entirely different ways than clinical depression, and neither sadness nor demoralization are really associated with suicide. So I really don't think that suicide is the right term at all, and I think as clinicians we should be careful to distinguish sadness, grief, demoralization from clinical depression that could be treated from a desire to hasten one's death. Although there is some data in the literature that raises a concern about patients in Oregon who have received prescriptions despite scoring positive on depression screens, I actually think this represents a limitation in the measurement tools that are used for screening for this, because they don't really distinguish between sadness and depression in this way. And then I was going to illustrate this with another patient that I took care of. This is Minhua. She used the legislation about a year ago. This is a cell phone picture that her son took of her walking into the bedroom before she took her medicine. Her thing was she wanted to walk in on her own 2 feet, even though she had had a very difficult time with ovarian cancer. And she, like most patients that I have cared for who use the legislation. She had a large family celebration. Everybody was there. She picked out very carefully the jacket that she's wearing. It's a beautiful embroidered Chinese jacket with dragons on it because they were a symbol of transformation for her. She walked into the room. Her son snapped the selfie, texted it to me, and she took the medication quite soon after that and lost consciousness in about 15 minutes. Somebody asked Wayne about this physician issue. One of the things that we have seen in the United States is that physicians may not have supportive colleagues and may not have a supportive institution. There has been certainly discussion about the nature of what kind of support is needed for physicians to do this work, because there is a huge potential for countertransference among physicians who are doing this, because it places you in a position of huge power. And I have actually seen a couple of highly negative physician reactions that have really never been written up. This is not in the published literature, but it clearly happens, and I think it is clearly important for a system of collegial support to be available if this is going to be legalized. In the cancer center where I work at the Fred Hutchinson Cancer Research Center, we developed a policy that is modeled on many institutions in Oregon, and so I'll say a couple of words about it to say how this works. Patients who wish to access the Death with Dignity law are directed to a navigator who is a social worker who helps lead them through the process. The navigator helps identify the physician for the second opinion, helps make sure all the paperwork gets done, helps make sure the consultations get scheduled if they are needed. This is not done by the palliative care service. Palliative care in most institutions wants to remain completely separate from this procedure, come in when needed for symptom control or counseling or family support or whatever, but does not wish to be associated with the Death with Dignity legislation. And I actually think this has been a healthy kind of distinction. It does mean that many patients are seeing a number of clinicians to do both of these things, to have the Death with Dignity process and high quality palliative care. But for the palliative care profession in the US, it's been a very tricky issue. And there are very few institutions in Washington, Oregon, or California that are requiring palliative care consultations for patients who wish to use this. There is an important thing going on about public reporting here. You can see that the data that I presented is, very straightforward and very accessible. I just thought I would show you, this is the Washington State Department of Health website where you can download all this information. It is open to the public and open to clinicians at both. You can see there's this whole thing about frequently asked questions. There's all the forms that you need. There is every yearly report that you can download and look at, and most of it has quite detailed aggregate reporting. And I think this has been a really important thing in reassuring both the profession and the public that the procedure is used responsibly. We have not had, this is Zurich, we have not had the issue of tourism that has been happening in Switzerland. There the advocacy group Dignitas provides physician-assisted suicide, self-administered medication to mostly, it sounds like, people with terminal illnesses from the UK and from Germany who come to Zurich to use their services. They die in hotel rooms. the legislation in Washington state and in all the American states requires that you be a state resident. Our cancer center will not accept patients who simply want to come because they wish to use the legislation. And by doing this, we have avoided the whole tourism issue, which, in Zurich, it strikes me as just creepy, that people are coming, to end their lives in a city where they know no one. So I wanted to end with a couple of observations. I do think that this whole phenomenon has taught me something very important about the nature of closure and how patients can orchestrate both the emotional end of their lives and the physical end in some very important ways that I did not expect. I do think, as a physician, the restrictions and safeguards that are in place do provide a level of safety for the general public, even though I recognize that these restrictions mean that the practice is not available to every single person who would like to use it. As a clinician, I'm a little unsure what to say about the use of this practice for example, a severe psychiatric illness. I do see that the public reporting is incredibly important, and in the editorial that Linda and I wrote for JAMA Internal Medicine, we called for an international registry so that cross-country comparisons could be made that would actually be instructive about what is happening. But I wanted to make sure to end with time for questions, and so I will end there. Thank you for this opportunity.
Thank you very much, Dr. Back, for such a good insight in what's behind the philosophical questions and with this proximity to practice. Thank you. So there are a few hands in the air already, please.
Well, there is a fraction of patients that indicate.
Excuse me,
before,
could you say your name so everybody
Gösta
knows who's
Garton,
talking?
Karolinska Institute. There is a fraction of patients that cannot take the medication themselves. So what, in the Oregon model, they are excluded. So what do you think about that? That's my first question. I have another one. That is, why should the figures that show that this possibility is utilized in a higher fraction of patients with time in Belgium and so forth, why is that the problem? When people get informed about this possibility, these figures will probably increase, and I can't see that it is a great problem. There are, of course, safeguards that have to be taken and so forth.
Yes,
but could
absolutely.
you comment on that?
Yes, I could definitely comment on both of those things. Thank you. So to your second point, is it a problem that, for example, the use of euthanasia is increasing in Belgium? Maybe you're right. Maybe it's not a problem. I don't know. I think the thing that puzzles me is I don't feel like I have a good explanation for it. I don't feel like it's explained in a way that I can see that it is part of a process of high-quality medical care at the end of life. And so it worries me because the potential for not high-quality use of euthanasia seems to me to be quite possible, more possible than with medication that you must self-administer. With regards to your first point, it is true that a patient who cannot take the medication or cannot swallow is not eligible for the Washington law. And it is something that I have to explain to patients. So, for example, a woman with advanced ovarian cancer who has had multiple bowel obstructions, who is obstructed, that woman will have to time taking her medication if she wants to use the medication before she gets completely obstructed, or she will not be able to use it. And I think that is just a practical aspect of using the law that becomes part of the counseling that we do. Is it ideal? It's probably not ideal. Is it a trade-off that seems acceptable given the current status and our understanding of this? I guess I would say my own personal opinion is I can live with that for right now while we're trying to figure it out, because I feel like we're still trying to figure it out. I do know, however, that there are patient advocates who think it's quite unfair. And I can see why they think it's unfair. Yes.
Yes, my name is Ellis Wallner. I have two questions. The one state that had said no was Massachusetts, and there was very strong support for such legislation, and then a very, very powerful campaign by the church and other groups stopped
Yes.
it. I'm surprised it hasn't come up again this year. And I also wanted to ask you about what's the situation in other states? Is it on the
Yes.
way in other states? My second question was about the number of people who don't use the medication, even though they've asked for it. The statistic you showed from Washington, it was very few who didn't use it, was what I recall from looking at statistics from Oregon was about 30 to 35% who didn't use it.
Yes.
Could you say something about that?
So with regards to your second point, the percent of patients who end up using the medication, the figure that I showed for the last year in Washington is indeed higher than it has been in Washington in the past. And in general, in Washington and Oregon, it has been about a third of the patients who have gotten a prescription that have used it. So I'm not sure how to explain what's happened in the last year. I don't know if that's an outlier or a trend. With regards to Massachusetts, that state, which, as you may well know, is a bastion of the Catholic Church in the United States, was the focus of a massive lobbying effort by the Catholic Church, who was determined not to let it pass in Massachusetts. So they probably spent twice as much money in Massachusetts as they spent in Oregon, and I'm sure it will come back. According to the advocacy groups, there are 10 to 20 states that are in the process of preparing legislation to have similar laws enacted. And most of them are pursuing the referendum route because it's very clear that public opinion is basically positive across the country. Yeah.
Okay, more questions?
Yes.
Yes, it's said that
Just a minute.
the costs of the thesis.
Gunnar Hagberg. I have read that the costs of the medication in the United States has increased more than 200% or something like that the last
like
years.
2,000%.
2,000%.
Yeah, most insurance in the United States will not cover the cost of death with dignity medication. Patients must pay for it out of pocket. When this practice first started in 2008, the cost of the medication was about $200. Last year, to use the same barbiturate combination, it now costs $6,000 to $7,000, and that is because of the pharmaceutical company not wanting to be associated with this, and also, I think, wanting to make some money. Because of that, the advocacy organizations have now switched in Washington State to a new cocktail, which is quite a bit cheaper. That said, it still costs about $400 to $500 out of pocket for a patient who wishes to purchase the medicine.
Can I ask you, you showed us the 3 top reasons for patients for asking for help like this, and you called them more psychological or even existential reasons, or for
Non-physical. Yeah.
Pardon?
Non-physical reasons.
Non-physical, let's go for that. Does this mean that you don't have a requirement at all for physical suffering?
There is no requirement for physical suffering. And in fact, there is no requirement for intolerable suffering, as in the Dutch model. So I, as a physician who evaluates people or counsels people, I don't have to make judgments about whether or not their suffering is intolerable. The patients don't have to make a case to me about how their suffering is intolerable. So I do think that simplifies things somewhat.
Yes. As you may know, the Dutch model does require by law that it should be an intolerable or unendurable, as it's called, suffering. Right. And who determines that?
Yeah.
From whose perspective? And
so as a physician, that seems like a tough diagnostic kind of call to me.
Is that the case in Canada as well? The term intolerable or unendurable suffering is a requirement, and who determines that, Wayne?
It is built into the law, as I mentioned. The Canadian law does follow the Dutch model in that respect, and intolerable suffering is the term built into the legislation. I don't think we have any consensus so far, anyway, on how that is determined. Certainly in the Netherlands, a great deal of emphasis is placed on the patient determining the level of toleration of his or her own suffering. And so in most cases, if the patient deems the suffering to be intolerable, the physician is not going to have really adequate grounds for saying, well, no, it's not intolerable. However, it's important to understand, I think, even in the Dutch situation, that a very high percentage of requests for euthanasia are refused by physicians. At least a third of requests made to physicians in the Netherlands are refused. And they can be refused on many grounds, and one of those grounds can be that while a patient is claiming intolerable suffering, the physician can't see that there is any intolerable suffering happening there. So Tony said quite correctly, this is a difficult diagnostic call for a physician. When do you override, or would you ever override a patient's judgment that his or her own suffering is intolerable? So this does get imported into the situation if you have any kind of suffering requirement embedded in the criteria for access. The only way to avoid that is not to have any reference to suffering and fall back on something like terminal diagnosis. But as I suggested in my own talk, I think that has its own cost because it will exclude some patients whose suffering truly is intolerable but aren't expected to die within the stipulated time period. So it's complicated, I think myself unavoidable, but I agree it does raise these questions.
Thank you. Do you have any comment on that?
You know, my only comment as a physician, you know, having a discussion about a patient about whether or not their suffering is intolerable just isn't that helpful to me in terms of figuring out what to do with them next, right? I need to figure out what their suffering is about, you know, what is manageable, what I can do, what their family can do. Being asked to say if it's intolerable kind of puts me in the position of being a gatekeeper rather than in a position of trying to figure out what can be done in this situation. And so there is a difference in orientation there.
Thank you. Question from the audience here, please.
Ulrike McLaughlin, I'm a physician in palliative care. I'd just like to make the comment that we already have the same problem in Sweden today when we said palliative sedation. It's because of intolerable suffering. And how do we judge that?
Yes. And certainly we face the same issue with palliative sedation too. So this is sedation, we often call it in the United States, this is sedation for refractory symptoms for patients who are very clearly at the end of their life. And so there are policies in most American institutions now where sedation for refractory symptoms is really only able to be used for patients who are expected to die within hours to days.
Fine. There's place for one or two more questions. Anybody? In case not, I thank the speakers and the audience for this. And yeah.